Thank you. Well, welcome everyone to our final clinic in this substance use disorder treatment series of 3D Project Echo. I'm Dr. Bob Seiss, addiction psychiatrist. Very much like to go around and make sure that everyone who is part of the hub can introduce themselves. Amber, please.
You'd think after all this time I would know how to unmute. Amber Rogers with Mountain Pacific Quality Health.
Hi, I'm Mary Aragones from Mountain Pacific at the Hawaii office.
And I'm Jessica Fry, also with Mountain Pacific up in Anchorage.
I'm Malcolm Horn, Director of Mental Health Services at Rimrock Foundation in Billings, Montana.
So we will continue to offer CE. If you could please respond to that survey that Amber's posting there in the chat. Same disclosure as always. Drs. Eric Arzubi, Rezo Sandigomi, and myself are owners and co-founders of Frontier Psychiatry. Reza as well as Amber do have these additional commercial interests listed here. The nurse planner will ensure this program is bias-free. Announcements.
I do have one small announcement. I think we've talked about this before. We did ask you to register with a list of questions, and we're going to resurvey you using those same questions as part of our evaluation for this whole series. So I know that it's, everybody's busy, but if you can take the time to respond to that survey, it really helps us in planning future echoes and see how we can make a difference in our communities. So thanks for that in advance.
Well, we wait to see if there are any further announcements. If you could remind folks to please, in the side chat, write your name, your role, and where you're connecting from. Any other announcements? Let's get started with the case. This time we're seeing patients in the emergency department. Mr. H.G. presents a 27-year-old man who has suicidal ideation in the setting of opioid withdrawal. He's currently homeless and says his employment is pretty informal, seasonal, does some construction, a few other things. His past psychiatric history is remarkable for long-standing depressive symptoms and prior heavy cannabis and alcohol use. He started abusing oral opioids about 3 years ago, said that he was able to divert prescribed opioid pain medication from family, friends, then ended up buying it on the street. About 8 months ago, he started using IV heroin, now estimates using about 8 points a day. Generally speaking, when people say points, that is 1/10 of a gram. So that's roughly 0.8 grams of heroin daily. A fair amount. Some people use more, and that's an expensive habit, in particular in Montana, that can oftentimes cost at least $100 a day, if not significantly more. He's coming in with active withdrawal, COWS score of 12. He remarks, "I really want to quit. It's destroyed my life. If there's anything I could do to get clean and stable, it would change everything for me." What can we do for this patient, in particular in the emergency department, and how has COVID-19 impacted this? Would love to hear from folks.
I'll just jump in because Lord knows I love to unmute myself. We saw patients across the board, not just with opiates, but all substances with COVID-19, just the stress of everything. Relapsing patients that typically had been very stable, really struggling, patients that were trying to get clean or sober. So they're like this gentleman in this case, I need to stop, I want to stop. One of the main supports is the 12-step community, and those meetings shut down temporarily. People can still access them over Zoom, but that is very different than being there in the room. And so COVID-19 really impacted people's their stress levels, not only just their internal stress, their external stressors, the way they could access care. If they didn't have the ability to link to a computer or have a smart device where they could join over Zoom, or they could not access those very frontline resources. Even from a counseling perspective, it was harder for patients to, they couldn't just show up at our doors and say, I need help. There was a process. And it's funny, not funny, but when patients are struggling with substance use, we give them all these hoops to jump through. Well, you need to fill out this, you need to call this number, you need to do that. Like, I don't know about anybody else, but when I'm not feeling good, I can't say that I've ever been drunk, but if I was drunk, I can't imagine I would really do like thinking very well. And so when we give people specific tasks, you have to do this to get help. If they're in a place where they literally cannot do that, we just create another barrier. So we saw just incredible numbers of relapse, instability, and we saw that not just with patients, but also with staff, because a lot of our staff are in recovery or worker program. And those staff members also identified that it was really difficult to access the supports that they usually did. So there you go.
It's some very, very pertinent themes that you touched on. Thanks so much, Dr. Horn. In particular, would highlight definitely, as we saw looking at the epidemiologic data a few clinics ago, opioid abuse and consequent mortality has really shot up in the midst of COVID-19, because a lot of the determinants of overall mental health, and in particular likelihood of using substances of abuse, have hit people hard. People are more isolated, less able to access care, in particular when it comes to mutual help groups, as you identified. So we'll start off by acknowledging the pre-COVID-19 regulatory context, move to talk about the COVID-19 regulatory innovation and how it's increased service deployment, talk about in particular our experience at Frontier Psychiatry, and then close doing an overview of what we've discussed over the last, now, keep me honest here, Amber, I'm going to say 5 months. I think so, right? Since April. Pre-COVID-19, the 2008 Ryan-Haight Online Pharmacy Act really dictated how, when, and where we could prescribe controlled medications, in particular buprenorphine. Specifically, the patient had to be physically present at a DEA licensed facility for the initial eval. So there was no way to do, for example, a home-based induction where you assess the patient via telehealth for the first time when the patient is at home. Similarly, there was no way that you could have some of the services we've seen come about in the midst of COVID-19, in particular, low barrier buprenorphine, making it available at needle exchange programs and other sites where people with opioid use disorder oftentimes present. That was impossible either, because those facilities certainly aren't DEA licensed. And we need to recognize that to this day, a good portion of the nation doesn't have immediate access to an X-waivered prescriber. This is someone who has the ability to prescribe Suboxone. Everywhere in the red catches those areas in which there is no one with an X waiver. Of course, COVID-19, and most recently, what came about under what was proposed under the Trump administration actually passed into law under the Biden administration. There's been suspension in the need for an X waiver, at least to prescribe up to 30 patients buprenorphine. So there is even more of a shift. The exception to the Ryan-Haight Act that came about with the declaration of the public health emergency was that you no longer needed either that in-person evaluation or the patient to present to a DEA licensed facility for telehealth to be the medium through which the buprenorphine was prescribed. A new bill has been introduced into Congress that would amend the Ryan-Haight Act and allow for controlled substances, both Schedule 3 and 4, so buprenorphine is included, could be prescribed without that initial visit, meaning that in person or presenting to a DEA licensed facility for telehealth requirements. It's yet to pass, but it's proposed, and this is very meaningful insofar as a change. Initial concerns about telehealth, and these have been fairly longstanding, predate COVID-19. There's a concern about, hey, will the treatment philosophy of the telehealth provider be in line and overall congruent with the treatment philosophy of the facility where the patient's presenting to receive care, or maybe the network through which this telehealth appointment's being set up? And this is no detail because for those of us who mostly work in the addiction treatment space, certainly some programs are going to insist on abstinence. Others, like my actual practice, does harm reduction. In other words, so long as it's relatively safe and there's no medical contraindication against treatment, we'll continue to treat patients even if there is use, so long as there's a meaningful improvement in quality of life and or reduction in use. Uncertainty about kind of the therapeutic relationship, and we may kind of almost laugh at this now after COVID-19 because all of our lives have been forced essentially into this medium of Zoom or an equivalent. But there still are some concerns that it's not the same therapeutic engagement. And certainly there are some things that are different. And some of those same things that we miss from those day-to-day conversations we had with our colleagues pre-COVID, we somewhat miss with patients now. That said, well, as we're about to discuss, the availability of services, thanks to telehealth and the ease of access, arguably trumps that as a benefit. A lack of trust because things are online. And this still is an issue for some patients who inherently distrust technology. And one thing that continues to come up is a concern that by allowing telehealth into a system, there is risk of losing patients to the telehealth provider. And it's something that needs to be overtly discussed and negotiated if a telehealth provider and a traditional system are going to work together. Telehealth is really compelling, in particular, because if there is a constraint when it comes to local people who are able and or willing to prescribe buprenorphine, this is a way to scale services across wide geographies, and something we've seen firsthand here in Montana. If the home site doesn't really have behavioral health services, and in particular, if the buprenorphine is being offered as part of psychiatric care, this is really compelling to have it kind of one and done offered via telehealth. So those patients who tend to be more complex and may be non-adherent with treatment require someone who is facile at continuing, say, buprenorphine when the patient is using prescribed respiratory depressants or abusing respiratory depressants of another sort. It's nice to have someone who brings that level of expertise. And oftentimes, providers at the home site want a higher level of care than they're able to provide. And that is frequently what triggers recruiting telehealth services. At the American Academy of Addiction Psychiatry 2020 annual meeting, which is fully virtual, there was a big theme about telehealth solutions for substance use disorder treatment. And they presented several studies in kind of broad strokes. The key findings revealed that there was increased access to medication-assisted treatment for opioid use disorder, not only in rural settings, but also urban settings. In particular, many of the traditional barriers to treatment, like linkage to a physical clinic, as was required by Ryan-Haight, having to go through significant wait time to get into an appointment, going through a standard referral process, a lot of that was pushed to the wayside. And things were freed from the physical constraints of the prior practice. Also, they saw that because wait times were less and care could be rendered in new places where previously it couldn't, MAT, in particular buprenorphine, could be offered to people leaving incarceration and for people who were using drugs and might present to syringe service programs, needle exchange, or injection sites. We'd like to briefly share with you what we've done through Frontier Psychiatry. That's the psychiatric practice where I serve as chief medical officer and addiction psychiatrist. We launched a subservice specifically focusing on providing care to emergency departments. We're currently live at all of these sites in addition to another 2 locations, and within the next 2 months, we'll be live at a total of 13 sites. And we have seen a steady increase in the number of patients we serve. We're on track to surpass 100. We're just getting the final numbers for August month. In addition to these emergency departments, we are focused on working with a few hospitals in the region, in particular, the SCL Health Holy Rosary Healthcare Facility out in Miles City. They, along with Eastern Montana Community Mental Health Center, have been very, very central in this effort to launch empath units. For those who aren't familiar, the empath unit is in many ways like a psychiatric emergency room, how it should be. For those of us who have been at big EDs in kind of level 1 trauma centers like UW Harborview, where I trained, the traditional psychiatric ED is pretty inhumane in that it's a lockdown subunit of the emergency department. In the case of UW Harborview, they have 11 rooms, which very much look like cells. And patients can oftentimes wait hours, sometimes half a day before they see a psychiatric provider for that initial assessment. The empath unit turns that model of care on its head in that the patient is assessed by nurse, social worker, and the psychiatric provider all at once when they present to the empath unit. They are medically cleared in some way by the psychiatric provider, so long as she or he is comfortable doing so, and or an emergency department physician at an affiliated ED. The psychiatric evaluation happens, again, up front, and one of 3 things happen. Either the patient is deemed as not being in high enough of a acuity of crisis to require observation, and they'll be engaged in services, given a follow-up appointment, ideally the next day. Potentially some medication change will take place. That's number 1. Number 2, they could be deemed in crisis, needing observation overnight. And they'd come into the empath unit, spend the night in a lazy boy, have access basically to a buffet of food with coffee and oversight by nursing, and then reassessed the next morning or several hours later by the psychiatric provider. Or 3, if somebody is floridly psychotic due to methamphetamine, decompensated primary psychosis, or some sort of other crisis that would make it really inappropriate for them to go into that kind of setting, they would be directly admitted to a psychiatric hospital. In those scenarios, you can see that sort of service offering is able to treat a large cohort of patients fairly quickly, and the majority fall into categories 1 or 2. As such, we really believe this is going to increase access throughout the region, and we'll be offering medication-assisted treatment, in particular, buprenorphine for opioid use disorder, as a core service offering, and can do on-site inductions. Here's our team. We are, and there's one person who didn't make it on here, we are currently 18 strong, 14 physicians, 4 nurse practitioners, recruiting a few more physicians and another nurse practitioner to join us this fall. And we have partnered with a tech startup out of San Francisco, Memora, that has really changed the basic platform for doing telehealth. In particular, you know how Zoom can be clunky when you first use it. It requires that you download the app, this, that, and the other. This platform's nice in that with just one click on a link, it will launch on any platform, be it a tablet, any sort of phone, an old computer on wheels. In addition to that, we're using an app that we've built to help create patient pathways so that people after the initial ED assessment, while they're waiting their follow-up, oftentimes with us 1 or 2 days later, we can send them prompts, check in on them, see how they're doing. And we think in particular, this could be really helpful for starting medication-assisted treatment to check on cravings, withdrawal symptoms, side effects, and any use. We're really grateful for a partnership we've been able to launch into with the Montana Community Foundation. And this is funded by the Arthur M. Blank Family Foundation. They've set aside a fairly significant fund that will allow us to take care of patients regardless of ability to pay, and in particular expand our pro bono outpatient services for the uninsured. In addition to what we just discussed, the emergency department and soon to be empath service offering, we also have outpatient clinics where we see over 1,000 encounters a month. So this will be a big support for patients who can't otherwise pay for services. Our immediate team that focuses on addiction treatment, which is shown here, Drs. Eric Arzubi, Rezo Sanigomi, and myself, as well as nurse practitioners Melinda Truesdell, Mark Ackerman, and Megan Lehman. And so, in addition to the core medication-assisted treatment piece, we very much incorporate psychosocial interventions. In part, that's why we partnered with Eastern Montana Community Mental Health Center, as they have chemical dependency counseling, strong linkage to mutual help groups like 12-step. As for true recovery, it goes well beyond just abstaining from substances on medication-assisted treatment. It really takes engagement in the kind of psychosocial interventions and supports that can shift the focus from use to healthy living and getting everything that comes with that sort of lifestyle. Did want to, and ideally get some feedback here from you all, did want to reflect on what all we've discussed and where we've come from April through today during these clinic sessions. We started out talking about screening, brief intervention, or referral to treatment, really the way that we can best engage patients across a system, be it a hospital network, outpatient clinics. This is how we can really help identify patients who would best benefit from treatment and really help inform them that services are available and whether or not they would need them. We also talked about several substance use disorders, in particular, alcohol use disorder, cannabis use disorder, opioid use disorder, kratom, benzodiazepine abuse, methamphetamine abuse. In going through these substance use disorders, we looked at the evidence, in particular, about the detrimental effect of these substances, looked to treatment, and if and when treatment in the form of medications wasn't immediately available, as in the case of cannabis use, we really looked at the evidence and looked for ways that we could connect with patients, have informed conversations, and keep them well positioned to acknowledge that even if they're enjoying the substance use in the moment, it comes at a cost. There is significant benefit from cutting back use, if not outright abstaining. And we also talked about treating ADHD in adults with co-occurring substance use disorders in particular, that doing so not only benefits them insofar as improving their ADHD symptoms, it also helps them cut back, if not abstain, from substances of abuse. What were people kind of most surprised by in this discussion? Did anything stand out over the course of these series?
Don't be shy, everyone. I was remarking to Dr. Seiss about how many new drug terminology lingo I have learned over this 10 or 5-month series. So, but I think I was probably most surprised about kratom, the fact that it's available on the street corner, and now that it's been pointed out to me, I see it everywhere, which is totally shocking. But this has been a wonderful series for me to learn more about this issue. Like to hear from some other folks as well.
Hi, I'm Marcella Barnhill. I'm a pharmacist at Mountain Pacific, and I've been working in the medication-assisted treatment portion of the Medicaid program for quite a while. When we first started with medication-assisted treatment, cannabis was a big deal. Providers didn't want their patients using cannabis. And over the 15 years or so that I've been doing this, we've seen the shift to where it's pretty much ignored. So I thought the piece that you did on both meth and cannabis was really important, because I think it does cloud the full picture that providers get of a patient. So that was helpful to me, and I can share it with other providers who possibly don't have the psychiatry background that you provide for us.
Really appreciate that, Marcella. And I think there's a temptation, if we do in many ways a triage list of priorities and engaging with patients, certainly when it comes to cannabis, to say, hey, that's number 4 on a long list of issues for co-occurring disorders. And maybe, at the top we have depression marked by self-harm ideation mixed with opioid use, as was the example you referenced, PTSD and some other things. And eventually, hey, if we have time, we'll get to the cannabis use disorder. We know cannabis use in particular, when it comes to PTSD and depression, it really complicates things and makes patients more likely to be treatment refractory. So however we can meaningfully address this with patients in a collaborative way, I think it benefits them and keeps us in line with our intent to really diagnose and treat any form of substance use or other general health or psychiatric issue we find.
Hi, my name is Cindy Jansing. I'm a social services director from Adventera Armor in South Dakota. And I wasn't able to be in on the medication assisted treatment for May 5th, but since it was recorded, that was very interesting. And then also too, with the treatment, it seems in the nursing homes, we are getting several residents that do have some type of abuse, which therefore there's some types of substance abuse psychosis. And your echo Zoom calls have been very informational for me, and I've been able to pass it on to the other IDT team. And so I just want to say thank you.
Thank you. That's wonderful you could join us. To wrap up on the objectives, we did acknowledge that medication-assisted treatment for opioid use disorder practice requirements pre-COVID were fairly restrictive. And scoping out a little, one thing we didn't touch on, in comparison to other countries like France, this is particularly true of the US pre-COVID under Ryan Haight. Now, with the regulatory innovation we've seen, at least temporarily, telemedicine deployment of buprenorphine and other treatments has become the norm. Time will tell whether or not it sticks. Really want to thank everyone for their participation across these clinics. Really look forward to staying in touch. Please feel free to reach out to me. I'm going to put my contact info. And Amber, may I ask, the chat isn't going to be actually recorded, will it? Like the chat won't show up on the video. I don't mind my email, but I was going to put my cell phone as a contact.
Yeah, the chat does not show up on
excellent.
video. It we do receive a recording of it that we don't send out though.
Okay, great. And I was just going to add my number. And it can be, any question, big or small, when it comes to medication-assisted treatment of a variety of substance use disorders, certainly not just buprenorphine, or psychiatric concerns, in particular if it's at the interface between a substance use disorder and non-substance use disorder, psychiatric concern.
I do have one quick question that just kind of came up at an event that I was at last night. And it was a discussion with the public about basically about medication for opioid use disorder and MAT in general. And some of the comments from the public are, well, that's just substituting one addiction for another. And, knowing that you can't go into all of the evidence-based medicine in an easy encounter, do you have any snippets? I also hear this sometimes from peer supporters because they've lived through it the hard way. They think that that's maybe the only way, and they being overly generalized. But do you have a couple of just snippets to share?
I definitely appreciate this kind of opportunity to talk about how MAT for opioid use disorder is really distinct. And one step back, how opioid use disorder is really, in many ways, a separate form of a substance use disorder in comparison to everything else. The stimulant use disorders, alcohol use disorder, cannabis use disorder. Simply put, once the opioid receptor system is out of whack, it don't go back. Now, I wish I coined that. It's actually Rick Reese, one of my mentors at UW. I don't think he said it just like that. I kind of worked on it a few iterations, but the point with it is really, if we think about the relevant disease model for opioid use disorder, it's not alcohol use disorder. It's not hypertension. It's diabetes or schizophrenia. In particular, just like in schizophrenia, once the dopamine pathway gets truly warped and we see long-lasting delusions, hallucinations, someone needs medication. Similarly, someone with diabetes is very likely at some point to be in need of medication to restore relative homeostasis. And that's a biological fact. Looking at the data overwhelmingly, we can say in opioid use disorder, if you take a cohort of 100 patients, get them detoxed off of opioids, all of them have opioid use disorder. You get them detoxed. You follow them for 2 years and you don't give them access to any form of MAT. So no full agonist, no methadone, no partial agonist, no buprenorphine, no antagonist or blocker, no naltrexone, nothing. In that cohort, 95 will see a return to use, and very likely over 10% will die. That's real. And I can't emphasize that enough to people, and very much try and use it as a way to change the narrative, change the focus. I almost want to kind of reference a talk about vaccines, but we're not going to do that. It's not pertinent here. When it comes to opioid use disorder, the vast majority of people, just like in diabetes or schizophrenia, need some form of medication. Otherwise, they're going to see a return to the state they were previously in, and a good portion of them are going to die. That's well demonstrated fact. And I think there is a temptation to conflate experiences in other substance use disorders. And like in the case of alcohol use disorder, we know overwhelmingly the psychosocial interventions, mutual help groups like 12-step, chemical dependency counseling, abstinent clean living, having a sponsor, that overwhelmingly is the bulk of the therapeutic benefit, well beyond, by like a factor of at least 2, if not 3-fold, more so than the medication-assisted treatment. Not with opioid use disorder. If anything, it's the inverse, in which the pyramid really has the MAT as the foundation. The psychosocial interventions come after. They don't have an equal yield. Still important, but MAT is really not otherwise an option. For those patients who do have some sort of philosophical concern about buprenorphine, I think that naltrexone is a really compelling option in that, and maybe it appeals to our puritanical core in the United States. We like to take away pleasure. So in this case, we're blocking the mu opioid receptors. They cannot see opioid and get the intended effect. And if you look at the data, if people can actually stabilize on Vivitrol and actually get on it at least 1 or 2 doses in, outcomes are similar with buprenorphine. So I think that can be a really meaningful option. I know a lot of people who feel strongly and were able to detox and stay abstinent for long enough. It takes at least a week, sometimes longer, to start the naltrexone. They did just fine. So I always think that's an important part of any MAT discussion. And every patient that we treat, we certainly bring it up as a treatment option. But for a lot of people, going through detox isn't an option for a variety of reasons.
That's helpful. I'll give you a chance to practice your line again so I can cement it in my brain.
You want to hear the opioid line again?
Yeah.
Well, it's recorded. I'll give it to. So yeah, once the opioid receptor system gets out of whack, it don't go back.
Love it.
There we go. I use it sparingly with patients. It's a little bit corny. Well, really special thanks to you, Amber Rogers. Thank you so much for your instrumental support in organizing this, keeping me honest and up to date in submitting everything I needed to. Thank you so much to Mary Argonis for providing technical assistance and support throughout all these clinics. Jessica Frey, thank you so much. Thank you very much, Dr. Malcolm Horn. Your contributions have been really invaluable and give us great insights into the psychosocial interventions, coordination of care, and a lot of concerns in delivering MAT. Really want to send a great thanks to everyone from Mountain Pacific Quality Health, Sharon Woodward, and others. Thank you so much for making this possible.
And give us your feedback on your surveys that we're going to send out. So this has been a great series. Anything else, anybody? Last final words? Okay, we'll close it out. Have a great afternoon.
Take care, everyone.
Bye-bye.
Bye now.